Hello, this is Danny Barella, and I'm presenting to you respiratory distress using a case-based approach. The calls that you hear are from actual experience I had while working as the ambulance district manager in Delta, Colorado, where I started out with a mostly volunteer ambulance service, created an ALS system, and worked towards an ambulance district a few years later. And our call volume was 70% elderly patients and 48% respiratory distress. Important definitions. Dyspnea is the symptom of feeling short of breath. Distress is defined as difficulty. Respiratory distress is defined as difficulty in breathing. And failure is inadequate breathing. Respiratory emergencies generally occur because of three mechanisms, and separating patients as to which of these mechanisms is your primary problem is going to define how well the treatment choices you have are going to work. So you either have a ventilation compromise, i.e. difficulty moving air, pulmonary perfusion compromise, where we have a lack of blood flow through the lung tissue, such as with a pulmonary embolism, and diffusion deficit, which is where oxygen is having a hard time exchanging across the alveolar membrane, either due to a pressure deficit or fluid inside the alveoli or a lack of surface area of the alveoli. As we review the anatomy of the pulmonary system, you can see that the lungs occupy a large part of your thoracic cavity, and each lung is filled with alveoli. In order to get air to the working part of the lungs, it has to go through the airways. The upper airway is highlighted here: nose, mouth, pharynx, and all the structures that tend to complicate upper airway obstructions. The passageways beyond the larynx are the lower airway, including the trachea, the bronchi, and its various bronchioles that branch off from there. The function of the airways is to warm, filter, and humidify, as well as conduct air to the lung. Within the lung tissue, you have alveoli, and the alveoli are made up of three different types of cells. In this nice diagram, you see how the capillaries, in red, align themselves very closely to the alveoli in order to allow for gas exchange. The little square there highlights the brain. This is where carbon dioxide and oxygen are exchanged with the blood. There are, as I said, three types of alveolar cells. Type 1 is that type that allows for gas exchange. Each alveoli is lined with a fluid called surfactant, which keeps it from completely collapsing, thus preventing atelectasis, the collapse of alveoli, and also improves the conduction of gases. At the same time, it improves the elasticity of your alveoli. These are produced by cells called type 2 alveolar cells. And roaming about, eating up any type of foreign material or microorganism that might be found in the alveoli are alveolar macrophages. They can also get between alveoli by going through little openings that you can see illustrated here called the pores of Kohn, and also between bronchioles through the canals of Lambert. Each alveoli has a rich blood supply, and this is why lung tissue is very vascular. Patient assessment. Remember to do a good scene survey looking for clues as to the patient's lifestyle, as well as what kind of dependency they may have on resources to help them breathe. In looking over the patient from a distance, identify if they are showing work of breathing. As you approach the patient, a primary survey begins with checking level of consciousness. A patient who is not alert is going to have a threatened airway, and that is going to be your most critical aspect of respiratory compromise. A focused history. We'll have another mnemonic to kind of look at how to do a better history for a respiratory distress patient. But most respiratory distress patients also benefit from having a good physical exam. Be sure at a minimum to get good breath sounds, anterior, posterior, and also to evaluate whether intercostal retractions are taking place or whether there is accessory muscle use and work of breathing. Additional parts of the physical exam on a person in respiratory distress would require you to look at their skin color and also the presence of jugular venous distension and edema. Ongoing assessment, everything that we're doing, whether it's checking oxygen saturation, respiratory sounds, auscultating, wheezing, you need to repeat those before and after treatment and regularly. As you look at the patient, try to determine early whether they're in distress or failure. A patient in respiratory distress has difficulty breathing and increased work of breathing. A person in respiratory failure has inadequate breathing, and as a result, they may actually have less work of breathing. They may be becoming fatigued and starting to wear down, or they have maybe a much, much higher degree of work of breathing, incorporating more muscle activity and therefore using up their oxygen supply. They fail when they cannot meet the oxygen demands. Obvious signs of hypoxia include cyanosis, but clinical signs include checking blood gases or looking at O2 saturation. Anybody with a SAT less than 90% is in failure. Further patient assessment always involves breath sounds. Particularly the sounds we want to listen to are wheezes, crackles, friction, and rhonchi. With this module are also a nice place where you can listen to these sounds if you're not familiar with them or haven't refreshed on them recently. The algorithm we use for a focus history is called PACE. The first thing we look at is progression. Is this a chronic or acute problem? What has led to it? This kind of goes with the sample, with the E for sample, events leading up to it. But also the progression implies did it come on gradually or quickly? So kind of like onset. Associated with pain. Does it hurt to breathe? And if so, where is that pain felt? Does it radiate to the shoulder? OPQRSTU, standard mnemonic you're already familiar with, can be used for any complaint of pain. And an associated complaint of pain should be followed up with. Is the patient coughing something up? And if so, what is the color and what is the thickness? Does the patient have a fever? And is the patient able to perform any kind of activity without losing their, without becoming so short of breath that they can't continue to act? That would be exercise intolerance. When the problem is ventilation, bronchoconstriction is often the issue that we're going to be working with. All of our bronchodilators are really only good for patients who have bronchoconstriction problems. So again, classify the patient as whether it's a perfusion issue, a ventilation issue, or a diffusion issue. Diffusion issues that we encounter fairly frequently are pulmonary edema, probably as a result of left heart failure, congestive heart failure. These patients will benefit from oxygen. Their position in the bronchodilated, or rather the bronchoconstricted patient, the classic tripod position works best. With pulmonary edema, not only will this patient want to primarily be upright, but have their feet dangling, even as transporting in the ambulance, have the feet down. Vasodilators will help this patient. Although EMTs do not normally use nitroglycerin for anything other than chest pain, as we move higher in our level of care, this may be a very important consideration. Occasionally, diuretics are used for people with pulmonary edema, though recently we've seen that they are really much less important. And in pre-hospital care, by far the most important treatment that we brought to the arena that helps the patient in pulmonary edema is CPAP. Either CPAP, continuous positive airway pressure, or BiPAP, bi-level positive airway pressure, where you have a little less pressure on exhalation than you do during inhalation, will help to improve diffusion in patients that have a diffusion deficit. Peak expiratory end pressure. This is a valve that can be placed on a bag valve mask if you're having to ventilate these patients, and it'll improve the diffusion of oxygen. It also is something the patient may be doing themselves. When babies are in respiratory distress and you see grunting at the end of each breath, this is a sign of a diffusion problem. When a patient with chronic obstructive lung disease or congestive heart failure is breathing with a little bit of a grunt at the end or with pursed lips, this also shows you that they are needing positive end expiratory pressure. The first bronchodilator that we select is usually albuterol. Albuterol, also known as Ventolin, is a beta-2 agonist. It works by affecting receptors in the lungs that are part of the sympathetic nervous system. It also has a slight vasoconstriction effect, although this is pretty minimal. And it also has a slight beta 1 effect. The difference between beta 1 and beta 2 is beta 1 is affecting the heart. Beta 2 is affecting the two lungs. It is rapid acting, and by 15 minutes you have the peak effect of the medication. Duration is up to 5 hours, but usually starts to wear off around 3. Cumulative doses may help. So if a person has reactive airway disease, RAD, or asthma, 2 or 3 doses in short sequence actually gives you a much higher effect and sometimes is necessary. Atrovent is another bronchodilator that works by a very different mechanism. Instead of stimulating, it blocks. So instead of stimulating the sympathetic nervous system receptor sites, this one blocks the parasympathetic nervous system receptor sites. Remember that these are two systems of your autonomic nervous system that are working in balance with one another. So where one tries to open the air passageways, the other one tends to keep it toned down. So relieving the patient of any action of the parasympathetic on their lungs helps the albuterol work better. So it often combines well. Medications that are a mixture of the two may be referred to as Combivent or Duonebs. Atrovent has a rapid onset and it peaks at about 30 minutes and it lasts for up to 6 hours. Rarely is it necessary to give more than one dose of Atrovent. I'm now going to ask you to go to the part of your module where there's the introduction quiz. Take the quiz and then proceed to case number 1.